Sound good? Okay, all the way up from Santa Barbara, Dr. Jeff Rohde.
Thanks, Steve. Thanks for the. So we were talking earlier. Anytime Steve asks for anything in the Bay Area, I always say yes, because actually this is my old stomping grounds. I grew up in San Jose, and then after school came back to the Bay Area to be one of the residents at the Palo Alto VA, and I lived right off 3rd in San Mateo, and this is like there's been times where we question if we shouldn't have just stayed because it's awesome up here too. But so thanks for having me. I'm really excited. Another part of my story and kind of how I met Steve was, and weirdly enough, we stayed in Oyster Point last night. Is kind of some of my story is in 2006, we started a company called Dental Compare. And Dental Compare is a technology company. Basically, like if you've seen CNET, then you've seen Dental Compare. It's like, what is cone beam? How does it work? All the cone beam machines on the market, they're all listed side by side. You can compare what they do, questions to ask your Patterson rep when they come to the door, about cone beam and all the applications of that. So we built that for almost 10,000 products. And we heard about this new company that apparently cuts hard tissue and soft tissue with their laser and okay, whatever. And so, and the headquarters of the company was at Oyster Point. That's what I was going to say. So we went to, over 10 years ago now, we went to a meeting in Chicago to interview this new company to decide whether or not we even wanted to highlight it. And I'll tell you, there was an aha moment for me in that meeting where all of a sudden I'm like, oh, dang, we need this. This is it. If this even remotely works how they say it does, then we need to get it. And since then, our story has been to use this platform as a way to, literally elevate our practice, right? Things that we weren't doing. We were talking earlier about crown lengthening. Like I was referring all the crown lengthening to him, right? And then now we do our own. And it's a technology tool that lets you do that very, very easily, right? And it's just a different method to do it, right? So that's kind of where I started was. Let me see if I can get this going there. There we go. So we always look at technology as a way to basically, drive better patient care, right? How we can be more efficient, how we can create a better sort of scenario for the patient to be seen. Are we doing better dentistry, right? And so, when we start to think about, what we want to talk about today, but I should actually back up and say, Steve kind of mentioned this. I love interruptions. I love tangents. I love questions. I have hours and hours of clinical video on here. This presentation is actually taken from something that's actually an all-day thing, and we're condensing it down into 2.5 hours. So if there's something else you want to see, then I'm showing you. I mean, just dive in and let me know. Okay. Second, and this is from something from another meeting we did. I was talking about all the support that you get after you buy the laser, right? There's clinical coaches that come to your office, an amazing install team, online resources, online communities. There's an annual user meeting. I mean, the company does anything but let you go, right? They want you to be successful. And a guy at the meeting was like, well, you're just saying that because you work for the company. And I'm like, well, first of all, I don't work for the company. I have my own practice. I'm appreciative that you invite me to come speak, but, and maybe I don't need to say this, but everything you're going to see is stuff I do. And if I don't think I can do it, I'm going to tell you that. I think a lot of companies in dentistry have kind of, created some marketing messaging that maybe wasn't quite true. And I appreciate that Convergent Dental lets me put this presentation together. And this is me, this is my stuff. And, it's not like they're off in the corner going, well, just say this, even though I can't do it, right? So, so just to note that the integrity of what we're talking about is extremely important to me. So that being said, it's awesome. Yeah, 90 CDT codes of stuff we do with this thing every day. So this is what I want, kind kind of the take home with this is when you think, well, what do we want to get away from this morning? So no anesthesia cavity preparations. Predictably, over 90% of our patients don't get numbing anymore for fillings, right? Second, soft tissue and bone cuts like mad. There's not a tool in dentistry that cuts like this, right? And it comes to oral tissues, including bone. And then basically the third thing is, well, the third thing is kind of like, well, so what, right? Right, so, well, so what? Well, basically it's how do you have better clinical income, better patient experience? That's what the effect it has done on our practice. We just got our 4th laser last week. I don't know if did I tell you that? We got delivery on our 4th laser. So we know it works and we know what it could do because we can cut tooth structure. Snoring treatment, we'll talk about that, and all kinds of procedures. And we were talking before we started about, like as a GP, is everyone GPs in the room for the most part, except for the specialists? There's things that we were not doing, like crown lengthening and stuff, that actually now with this tool makes it really easy to do. I mean, you almost have to just point it at it and it's going to do it, right? So that's where we saw this incredible increase in stuff. So so just to give you a little context, and by the way, let me know if I'm blocking you or anything. Just to get a little context, I'm going to show you upper left lateral incisor. This is not deep decay. This is not a super complicated case, although I'll show you some. But what I want you to look at is, so what I'm going to do is first remove a little gum tissue over the decay area and sculpt that back. Any diode laser users in the group? So you have a diode. So you've seen how it kind of melts and drags and chars tissue as it cuts, right? And we'll talk about why it's different. But what I want you to do is look at how it's cutting the tissue, look at how it's cutting the tooth, how it removes decay. Everything you'll see in this video happens to be anesthesia-free. So let me play that for you here. So step 1, applying some energy down. And when we do this for the hands-on, we'll kind of go through this again, but you're holding it about 10 millimeters away from your target, right? You just kind of hover it there. And I'm going through it, I'm just kind of removing some of that tissue there. Notice how much bleeding, or I should say lack of bleeding, is happening. And then go into the part where we're grabbing some of that enamel, creating our bevel for that class 5. That flash that you're seeing, you're going to see that today when we do our hands-on. That's called the laser plume, but it basically is kind of a release of energy as it vaporizes that tissue. And then we just kind of sweep through, get the rest of the decay, and I kind of finish off that little gingivectomy there, right?
Soft tissue.
The soft tissue in this case was not. There are times where, there's plenty of times where we do. The big idea with teeth, no anesthesia, it's awesome. With soft tissue though, like I can trough around a root tip for the extraction to get bone out if I had like a broken root tip. But that patient's numb. Huge frenectomy where their lips basically tacked onto their maxilla and you're just really digging in there. I'll do anesthesia for that. Kind of the rule of thumb that we talk about is the deeper you go, the more likely you need something. But topical stuff like this, all day long. I mean, that's really easy. Another example of that would be troughing around for a crown. Instead of we don't pack cord anymore. We just clean it up and that's it, right? So, but I'll point out when we get to that soft tissue section, I'll point out when, like, and what kind too. Like I might say topical, it's a compounded topical, but I'll go through all that. So let's, I'm going to skip past that. So let's talk about just the technology, like how this thing even works. And when we're at Dental Compare, what we were noticing is technology was evolving pretty fast. I don't know, it seems like it's an exponential change, right? I mean, think about, all the advances with AI now and everything, and we have an expert on AI right in the room, so we can ask him all our questions with that. but we're seeing kind of a rapid change in technology evolving. And we started to kind of ask ourselves, okay, well, like in dental compare, how do we wrap context around that? So what I want you to think about this morning is basically 4 different ways that if you're that, and this isn't lasers now, this is any product you're going to look at. What are 4 different ways I can look at to see if this is going to be a right purchase for my practice, right? So let's look at the first thing. So increase breadth of procedures. You know, is this going to let me do things I couldn't do before? Like if there is a molar endo machine, I would totally buy that. Like something just attached to it and just do the endo. I would buy that because I'm terrible at molar endo. And so, you know, you start to think about, you know, is this going to add things to my practice? Is this going to let me do things like crown lengthening that I just never did before? Okay, so that's one thing I want to see in any technology, right? Increased efficiency. Is this going to make me more? If it slows me down, if my filling takes longer, if the surgery takes longer, like I don't want to slow. I want to create efficiencies within the practice, right? So if there's ways to do that, then that seems to be something I would want to invest in. Next, new patients. I mean, we all kind of want to grow our practice, right? So is there a way to do it? Well, we did. Do you guys ever do like that hot towel machine? You know, where like you get hot towel, like in, and the do you guys have it? We're like that didn't bring. We're like, oh, it's going to create a great patient experience. Didn't really bring new patients in. We put a Keurig out in the waiting room. Didn't really bring new patients in, right? Like for all the patient experience things we could do. But it is important, right? If I can integrate a technology in that's going to actually get people who are like, oh man, you guys got to go see Jeff. They have ... right? Then that would be potentially something to invest in. And the last thing then is better dentistry. The one thing I never want to compromise on is the quality of care that we're delivering, right? So when we start to think about, oh, I'm going to add a laser beam to our practice, right? And then like kind of have it be this gimmicky thing, or it doesn't really work, or it's not quite, you know, the clinical results are compromised, well, then it's not worth investing in. And what I hope you'll see today is that we're certainly not compromising on care. If anything, like that soft tissue procedure you just saw, that's going to be healed within 24 hours. The crazy thing about this laser is that, and let's get into why then the laser makes a difference. Let's look at just better dentistry. Let's just look at that first. That cutting heals within 24 hours that you saw. Piece of cake. It's going to feel like they had maybe a little hot coffee for about half a day. We 2 weeks ago in Walnut Creek did a live dentistry thing where we were doing live procedures all day long. We did a mucocele and a snoring treatment and cavity preparations. And on a 14-year-old I never met before, we did this super deep frenectomy, like super huge. And he was cool. He did great. That I talked to mom that night after I flew home. He didn't need any Tylenol or Motrin at the end of the night, and it was healed in about 1 week, right? Crown lengthening. You know, when we do crown lengthening, you know, like what's the normal amount before you want to go to your final restoration? Like how much time do you want to give it? We were always taught 6 to 8 weeks, right? Before you go to the final restoration. With this laser, when I do crown lengthening, I can either go that day or within the week to the final restoration. That's how fast it heals. That's the difference with laser technology like this, right? So we definitely don't want to compromise, and I don't think we are. So that's part one. Increased opportunity. Hey, we're going to get you to the final restoration. We're not going to numb you for this filling, right? That's something that people can talk about. We got so busy with our practice that we actually had to bring in a pediatric specialist because we haven't had to numb a child up for a traditional filling in over 10 years, right? So it's significant. It's a significant change, and it's a significant conversation opportunity. All right, next up then, efficiency. You're not numbing, saving a lot of time, right? And increased breadth of procedures, all these things that we weren't doing before. You know, and what I want to do today with our time is not necessarily have this be the Jeff Rohde show. I want this to be like, we were a GP office. We did billings and cleanings, and we just and slowly over time, using this as a platform, we've added this. So what I hope is you see more of the possibility, not just like, oh, that's cool, he's doing that, I'm never even going to touch that. Well, I want to show you a bunch of stuff that you can do and you will do with this technology. So all right, questions so far? Yeah.
What do you mean, no bicep? You still do the fitting.
So you still do, yeah. So what we mean by that is the second bite adjustment 3 days later, when they were so numb that they couldn't tell, and then, so yeah, and I'm glad you asked that, because like, how are we doing the bite adjustment? My handpiece isn't in a drawer. It's right next to my laser, and I use it in conjunction with both all the time. And I'll show you some cases where we do that. That's a weird message that I feel like I got along the way was, like, oh, you don't need your handpiece. Well, how are you going to finish the composite? But now they're not numb, so they really know if you have it dialed in just right. But yeah, we're still cleaning it off with the I just have like a little finishing diamond I use for that. Pretty easy, right? Yeah. Yeah.
The other side, higher up.
It was, so you're already like 10 steps ahead. I love it. The other side was up. If I'm only going to the decay, then I'll thin it from the inside against the tooth, but not take the height off, right? So I can just imagine the width of the gum is this much. I could just take like half of that, go in there and remove the decay, and then that'll fill back in. The height does depend on, and I'll let you take over this for the next hour. No, the height does depend on where the bone is, right? So if I have 4 millimeters to bone and I move back 1, it's going to stay right there. That's different from diodes that I used. And we'll talk about this in a second, but diodes add heat, which potentially creates inflammation, which creates recession. So when I sculpt that, it's going to be right there forever in a good way. And if I don't want a height change, then I won't touch it that way. Now, if I do have, let's say I'm going to remove 2 millimeters back, and then the bone level's right there, that tissue is going to repopulate and grow back over and cover it at least by 2 millimeters and recover that. So in that case, that's where we would do like an anterior aesthetic crown lengthening. And I'll make sure we get that in there, because I have a great case that shows that where we're fixing variable heights of the gingival tissue by removing bone right in between. This laser is so precise, I can do closed crown lengthening by going in between the tooth and the gum and removing bone across the facial surface of that root. Then you count your 2 millimeters from there. Yeah. But good intuition on that. That was good. Okay. So how do lasers cut, right? Your diode, your erbium, your millennium technology, like, how do any of these lasers cut? Well, they cut by absorption, right? Like this light right here shining down, I don't feel anything. I can see it, right? But if I put my hand under a restaurant heating lamp, that feels very different, right? Well, what's happening with that? Well, a restaurant heating lamp puts out infrared energy, which then is absorbed by whatever target, in this case, my hand, right? So the way a laser cuts is people figure out where a particular wavelength will not just slightly be absorbed and make my hand feel warmer, but be greatly absorbed into that target tissue to the point where whatever target you are trying to cut absorbs so much of that energy, it literally obliterates that molecule, right? So if I want to cut things like a steak, I could figure out, well, at UV doesn't really cut the steak. Infrared cuts cuts steak and more. You can figure out what wavelength is more or less absorbed into that tissue that we want to cut. Okay, so let's look at an example of that. So if we look at where we are here, down here we have wavelength, right? So shorter wavelengths, longer wavelengths. Right around in this area, you have the visible wavelengths, stuff we can see, right? Red, orange, yellow, green, blue, purple. Down at the bottom, then you have like UV, X-ray, gamma ray, and then over on this side is all the infrared stuff over on this side. And then you have like microwaves and then radio waves and all that stuff. So with the wavelength, then they figured out, okay, I'm going to shine and we'll follow this blue line first. And in the visible wavelength, they said, okay, we're going to shine this light at water, which is what the blue line is. And as you shine the light at water, what happens? Well, we know, right, that it doesn't really absorb well, into this. This water ball is not dark. It just looks basically translucent. The light comes in, passes right through the water, doesn't really interact with the water and keeps going, right? Compare that to a wavelength over here where we have a really high absorption for water. And that's where, if you've seen erbium lasers like the Waterlays, you have the Waterlays MD? Oh, the I+, yeah. So basically the way those lasers cut was, and weirdly enough, we use the word cut, but it's not really cutting, right? What it's doing is absorbing efficiently into that. And the Waterlays team picked a wavelength that was so efficiently absorbed into water that it basically, the way that cut was to find that water molecule. The water molecule absorbs that energy so efficiently, it literally vaporizes that, ablates that water molecule apart, right? Now, the way it cut though, so if it's in soft tissue, what's most of cell structure is water, right? So it cut soft tissue very well. But how did it cut tooth structure? Because how much water is in tooth structure? About 3 to 4% in tooth structure is how much water is in there. Right? So how did erbium lasers cut? Erbium lasers would fire a beam down at the tooth, find that water molecule, explode that water molecule, and in the doing so would blow chunks of tooth structure off of the tooth. So collateral damage kind of cutting, right? So this is to me how I envision more of what erbium lasers were actually doing, right? Is essentially exploding that molecule, right? So and that laser would do okay, but with that explosion, you could only turn it up so much. Like what I was told was about 30 hertz would be enough to start cutting enamel. So 30 pulses per second, 30 of these per second, right, would start to basically tag that tooth and start to essentially chip away at it, right? Not unlike if you had a hammer and chisel and you're just going to basically tap away pieces of that tooth. That's how it actually cut, right? Then, and looking more into this section then is where diode lasers kind of fell. So our diode lasers, we'd take it and touch it to a little piece of articulating paper to activate it. Well, the target tissue for diode lasers is actually pigment, right? So pigment like melanin and hemoglobin in tissue. But that's why when you got into like the retromolar pad area, when it was all this white, thick connective tissue, it didn't really cut very well, right? So what do? We activate the tip, and that's when the laser stops even really cutting as a laser. So diode lasers, you're not really lasering. You're basically hitting that pigment. That's your target. And when you hit that pigment, it causes that glass rod, that little fiber optic tip, to heat up, and now you're cutting with heat, right? Make sense? So this is kind of more of what the cutting with diodes actually look like. Is you get this kind of, you got all the laser energies going in there, and it's basically using heat. So what is that like? That's more like electrosurge, right? So imagine I'm going to take a fireplace poker and put it in the fire until it turns bright red, and then I'm going to cut with that, right? That's what diodes do. And the problems with diodes is that here's where you're cutting, but you're going to get some bleeding. It's stopping the bleeding by charring the tissue, essentially, right? Cauterizing. But then the thermal effects go way out into that tissue, right? If I'm going to take let's go back to our steak again, right? I'm going to take a steak, throw it in a hot pan and sear it. If I take a cross section of that, you'll see those thermal effects cooking into the steak. And this is what diodes do too. So I might be cutting here, but the effect of it goes farther than the actual thing. So that's why you get, I loved your question, because that's where you get the unpredictable gum lines with diodes, right? And pretty sore healing because you basically burned them, right? And I use that for years, right? I mean, it's not bad dentistry. It's just now we have something better, right? Because how does this cut, right? This laser that we're all going to be practicing with today. So let's look first at the green line. So what the green line is the absorption curve based on wavelength for hydroxyapatite. And how much hydroxyapatite is in two structure? 80 to 85%. Right? So this was the aha moment when I met Steve for the first time. Like, wait, what is this doing? Oh, you're cutting the stuff that we work with every day? This is actually, it's not byproduct ablating water and then exploding chunks of two structure off. This is directly dissolving enamel from the top down, right? Right? And so instead of pulsing at 30 times per second, this laser pulses 1100 times per second, right? So bing, 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 very, 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 very fast, right? All right, we're going to practice that. We're all going to clap our hands 1100 times a second. Go. Go. Right? So it's very fast, very efficient. Now it's a laser, so it cuts where it's pointed. So the way it cuts is like, you guys in your dental kit, you might have in your practice, ever have those burrs where it's just this stainless steel shank and then the diamonds are right on the base of that? Imagine that's how it cuts. So when we go to do our hands-on in a bit, we'll remind you of that it's not hard, it's just different. We're used to a burr dropping down and then moving it sideways as a side cutting tool to remove the decay. This only cuts where it's pointed. So imagine cutting a class 1 with that diamond burr, with the shoulder burr, tissue safe burr, whatever you want to call it. Imagine cutting a class 1 or class 2 with that. That's how we cut, right? So the approach is a little different, but we'll go through that. So that's hydroxyapatite. So if that's true, you think about a burr, scrapes a layer away, exposes a new layer, then it scrapes that away and scrapes that away. The way this laser cuts is you ablate a layer and then ablate another, and then keep vaporizing down and layer by layer. So if anything, this does cut more like this thing when we're using it, right? It cuts more like a drill. It just cuts end cutting only, and so we'll talk about that too. Side note, also works at the secondary peak for water. So target tissues for most lasers are one thing. This laser actually has 4 different target tissues. The first one is, we talked about hydroxyapatite. Second target tissue is water. And what you'll see is a little more, I mean, you might have noticed that compared to some of the biolace techniques, where it's not quite at the same peak absorption for water. So it's a little less, which means a little less explosive effect. So you get a little more calm or more smooth transition on soft tissue, right? So that's the second thing. Third thing, collagen. It actually will cut collagen very nicely, but it also has a weird peripheral effect on collagen. So as you're kind of cutting through, and you're cutting through that tissue, the peripheral energy causes that collagen to actually contract and shrink. And I'll show you a video of this happening live. But what it does then is, as I'm cutting through, it shrinks down that collagen, which effectively coagulates those blood vessels, lymph vessels, so you get no bleeding. So it's not causing no bleeding from charring or cauterizing, it's causing it from essentially hemostasis, from shrinking that collagen as it goes through. Crazy, right? Okay. Fourth thing it cuts is plastics like composite resin. So it cuts composite like mad all day long. Sometimes it's cutting composite so fast it looks like there's literally filler blowing into because it's cutting the resin, and it looks like talcum powder is like blowing off the tooth. It cuts it so fast. So that's why. So what does that mean for us then? What's teeth? You know, teeth is hydroxyapatite, water, collagen. Bone, hydroxyapatite, water, collagen. Soft tissue, water, and collagen. So biologically, this will cut anything in the mouth. And that's where then they came out with more things like, oh, well, if it shrinks collagen, maybe we could use it to treat snoring. And when we get to that section, what we're doing with this for snoring is firing a non-cutting power at the soft palate. Because a lot of snoring is just, you know, that soft palate. This isn't not necessarily sleep apnea, but palatal flutter as it relates to snoring when your soft palate kind of falls down. Like, you know, when you have that patient open, you look in the back of the mouth and you can't even see the uvula, that patient, right? That's a different source of airway trouble. And what it's doing is tightening that collagen in the palate to get it off the tongue, to decrease airflow through. So we're treating snoring with this too, all off of this same idea, right? Which is why I make you guys sit through laser physics at 9 o'clock in the morning, right? So just so you could see it. Okay. So questions on that then? Questions on just kind of what the laser's doing or anything and how it works, how things are absorbed? So thin veneers. So here, this is interesting. I'm glad you brought this up because here's where I think marketing has kind of screwed around with what we can actually do with this stuff. Because some of the ideas behind removing veneers is like, well, the laser beam's going to go right through the porcelain, the glass, and then bubble up that resin that'll pop it off. Which kind of got a little bit sort of extended in the story to say it can remove crowns, right? Because the beam has to be able to go through that glass. So this will also bubble up the resin on a thin transparent veneer. But think about a Bruxer crown 3 millimeters thick. You're not, I mean, you can correct me if I'm wrong, but I haven't found anyone who was able to do, think PFM. There's no way that beam's getting through there, right? So not necessarily, well, there is one thing this does very well is it shatters zirconia. And I don't mean like explosively shatter, but like those glass doors, if I threw a baseball at that door and it like kind of spider fractured the zirconia, it'll actually like break that apart. And then you just use your burr to pop the pieces off. So it does help with that a little bit, but it's not hitting it can't get through to the resin, right? So those patients were numbing up, we're hitting it with the laser. It is, the joke we have is instead of using 12 burrs to remove the crown, we use 1, you know, because it breaks it apart enough, you know. So but that's why, great question, because that's why we want to go through the laser physics so you know, like, oh, my laser can do this. So it's like, well, what's the target? How is it working? How is it interacting with the tissue? All right. I mean, that explains we're basically playing with infrared flashlights today, right? I mean, it's a little fancier than that, but that's what it is, right? All right, so let's then talk about how we're controlling that flashlight. So on the screen, this is the actual screen that you guys are going to be playing with in a little bit here. Okay, so on the screen you have what handpiece you're using. There's a couple different handpieces you can have over here. There's different spot sizes. One of the terms we kind of use is virtual burr block. Think 1/4 round burr versus a number 8 round burr. So you could change the size. The way it changes the size of the beam isn't by gating the beam. There's no aperture that changes. What is in the, here, I'll have you guys kind of just peek over here. What's in here in this sort of clamshell side over here are these, as the beam comes through, there's these turning mirrors that move in an X and Y direction, and it bounces the beam around, right? So what it'll do, you can see down in here, where basically it's, here, let me go back and I'll start it again. It moves that beam around in that pattern to create basically a concentric circle that creates the different spot sizes, right? So in the 1.5 millimeter diameter pattern, there's 54 different points in there that it's hitting at 1100 times a second, right? So this is basically a computer controlled flashlight that moves that beam around to give you that different pattern and spot size, right? All the way down to 1/4 of a millimeter. And that's how it controls the beam, right? So that's one of the reasons it cuts very fast and very efficient is you're not losing power. Older lasers, like older CO2 lasers, conventional CO2, you change your power and diameter by getting farther or closer, right? So if I'm shining my flashlight right here versus across the room, less dense over across the wall, that's how they gated power, right? But the great thing so then you have some water controls, you have power setting here. This is how much power will come out, but it's all basically controlled by this foot pedal. So this foot pedal is just like your handpiece foot pedal. And we'll be practicing like light and harder techniques when we go to do it together. But when you push on this, you want to cut a little bit, you just press light, just like your drill, right? If you want to really ramp up that drill, you press harder, and then you just press harder on this. So this will gate power as you go. So that first video, that first class 5 video that we saw, the difference with that video that you can't see is my foot is going up and down the whole time. So it's light in that tissue, harder in enamel. I come off it for the decay, right? Because the decay is just less dense. And we're moving in and out of that power. And you just, again, the technique, people ask, well, what's the learning curve on that? About a day. I mean, you'll see, even doing this today, what your foot does, and we'll be practicing that, right? We have apples to try it on, so it's really easy to see the spot size. I can like gouge a trough out of that apple, or I can remove 1 cell layer of the skin at a time, right? It's that good, right? So if I'm using it to say sculpt gingival tissue on, a child has hyperplastic tissue around brackets, I can just open up to a wider spot size. And rather than cutting with like a scalpel type cut, I can open that spot size up and literally sculpt that tissue back 1 cell layer at a time with no bleeding, just like you saw in that first class 5, right? Pretty crazy. It's actually more like festooning. I didn't really love that removable denture class, but remember the festooning thing where you make the gums look all pretty? It's more like that, right? So we'll be practicing with that too. There are a couple different hand pieces that are available. This is that sleep hand piece. It has like a little tongue depressor sitting outside, so you can push the tongue down and then it shoots straight through at the soft palate. You also have a straight hand piece and a contra angle hand piece. And in the contra angle hand piece, this is where we're going to be using today. There's a little mirror right at the end of that just hits that, the laser beam hits that and then bounces down toward the tooth, right? And that's how that part works there. Questions on the machine? So we have a 9.3 micron wavelength, pumping out, being controlled by galvos to create different spot sizes, to fire at the tooth, to be highly absorbed into hydroxyapatite water, collagen, and plastics. That's the big picture, right? The straight hand piece I like for things like frenectomies or gingival recontouring. It's more like you're holding an airbrush, just painting at the tissue. But all these are fancy tubes to deliver the laser energy. So the laser energy goes up the arm, out, and then out the tube, essentially, right? All right. So again, are we asking this questions like, how do I take advantage of technology I have? Where, is this something that is like even relevant to me? Well, I mean, we're using this for all kinds of cavity preparations. Let's look at a very easy, I'm going to skip past some of this just for time. But we're not doing start and stop dentistry where you're pulling out the viscostat all the time, right? So let's look at a real life example as a GP, right? So I'm going to do a subgingival class 5. Let's talk deeper than what we just saw. What's step 1? Is calm everyone down, then numb the patient, then retract the gingiva, then go after the decay, then do all this stuff, right? Well, this first part, if we're doing it right, is at least 5 or 6 minutes, right? I mean, to start. A buddy of mine who I went to school with, who's now a pediatric dentist in San Diego, we had this argument one time. I'm like, he's like, there's no way you're faster than me. I'm like, because he's like, I'm good. I got my 330 burr. I can do that pedo class 2, and I'm fast, right? I'm like, okay. So let's start your procedure, and we're gonna start mine, right? So what's step 1? He's like, well, I get my 330 burr out. And I'm like, no. You get your topical out, right? Then now you can do, and if we're doing the topical right, that should be at least 30 seconds. I can't tell you how many times I'm doing the, oh, that's good enough. Right? Like with the benzocaine, right? But if we're doing it right, that's 30 seconds. You inject, then you wait, let it soak, right? Then you start, and maybe that part is still under a minute for a class 2, right? But I'm going to show you a pedo prep. So fair, maybe 40 minutes is on the long side, but 25 minutes for all that, maybe 20, right? So, but compare that with the laser where, hey, I'm really excited we're going to use a laser today. Do you have any questions? No, you don't need to be numb for this. Let's go, and then clean everything up. And if you do have any tissue work to do, I'm going to use the laser to do that, right? So let's look at another one, another example of that. And this one, I have the addition of some composite resin. And the composite we're going to dissolve away too, so you kind of see how that goes. So oh no, you're good. In this one, we're going to see soft tissue, composite, decay, enamel, dentin, all being cut with this one, okay? Oh, back to your question. You were talking about gum heights. So here's that line I want to be aware of, right? The transitional from attached mucosa to unattached. And if I have enough tissue here, this is kind of a non-aesthetic zone, then I don't mind lowering it because I have plenty, versus a lot of times those premolar teeth have a mucogingival problem, right? And there's just like a millimeter of that tissue, then I sure don't want to cut that away. So yeah, I love that question from before. Okay, so let's cut this. So your angle is going to be along the long axis of the tooth, because if I'm going to just cut gums, this will also cut tooth, right? So I want to come straight down at it. And then you're just stepping lightly on the pedal and painting that tissue away. Again, look at the amount of bleeding, or I should say lack of bleeding, that's happening. And we'll just kind of gently paint that away. All I want to do really is expose that, but I don't want to leave a U-shaped defect. So that's why we kind of bring that preparation out to a little bit farther along that gum line. Now turn your end cutting beam toward the tooth and start dissolving that decay away, right? And I'm just going to kind of mop that off. You see that plume changes a little bit, right? It's the brightest in thick enamel. And you'll notice that when you're cutting a little later. And then a little less bright in dentin, and there's no plume and decay. So that is somewhat of a indicator of what tissue we're in. Like if I'm firing and there's no plume and it's gently dissolving away, that's decay, right? I'll bring up some of that, but I want to grab your question. Yeah, you guys hear that question? So I'm not changing settings. I'm changing the foot pedal, but that's the great thing. I don't have to go back to the screen to go beep, beep, beep. Oh, and now I'm doing soft tissue. This will cut everything. So it lets me focus on the case, not on, or what joules or hertz or fluents or watts did, like I don't even know, right? But you don't have to know any of that stuff. You just basically, I'll put that governor at like 30% power. And this whole case, I don't even think I got that high, right? It's way powerful enough, to cut that, but it's all foot pedal. Yeah. So what does that mean then, right? Okay, so if I see there's a little kind of brownish spot, I can just lower the power to like 10, just to give you real world numbers. I could lower the power to 10 and go point it at the tissue and just slowly paint that tissue. And in this case, decay. And if there's no plume and it's moving, then I know it's still decay. And then as I get through it, all of a sudden this little sparkle of that plume comes back. Now I'm at healthy dentin. And 10's not enough to even cut that dentin very fast anyway. So what we're really talking about is kind of tissue selective ablation. Like, and this is the way I describe it to parents sometimes. Like, how does this laser work? You know, because they think it's going to be like a lightsaber. And I'm like, I wish it was like a lightsaber, right? But essentially what this is doing, I say, well, it dissolves decay and then stops at healthy tooth, right? And for all intent and purposes, that's exactly what we're doing, right? And so I use it almost like a caries indicator, right? I go, oh, well, where am I at? You know, is there any decay left? I just park it at 10% power and paint away, and you can see it, right? Very, very easy to do. All right. Make sense? Questions on that case at all? Yeah, so remember that screenshot of the screen that had down at the bottom was that little bar 0 to 100 on power. I set it for most teeth things, I'll set it at 30%. And then but then the cool thing is you have with the foot pedal then, and again, you'll be practicing this. That means the whole travel of that foot pedal will be that 30% amount of power. So 0 all the way down to 30 gives me a lot of play in that. If I have it set to 100 and I'm trying to just get 30% power out of that, it's harder, right? So imagine you have it set to 30 and you go halfway down, you're at 15. If we have it set to 100 and you go halfway down, you're at 50%. That's a lot of power coming out. So we use that as a way to, again, kind of gate the power so I don't have to look at the screen. Now I can just fully focus on that. And if I feel like I'm cutting tissue and it's not enough, add more power to that.
But within that limit, they'll cut and
Everything, and all based on that idea of what's absorbing that laser energy. So you're just moving. Now the rate of absorption might be different. There's times where I'm cutting that retromolar pad area. I'm at 50 or 60 to get it to cut because it absorbs differently into that tissue than to hydroxyapatite. But same idea, you just basically do what the tissue's telling you. But it'll cut everything.
that once you're done with the decay, it's not hitting the tooth anymore.
Well, it is, but it's just such a low power, it's just not efficiently cutting. It'd be like having your slow speed out at almost a stall out speed. It's just not cutting very well at all. So it slows down the cutting to a point where it's almost negligible, but enough to keep removing decay.
Right, but then you're also creating a tooth, right?
Yeah, you're making a hole. So if I want to, and let's say I wanted to put a little retention in there, or I wanted to shape it, yeah, totally. Then now I'm stepping on the pedal harder, and then like that's how we're going to cut a class 2 today. Is just hit the power up and then create the shape you want. Yeah, thanks. Yeah.
Just to add to that a little bit, Dr. Rohde talked about this. One of the transitions in the learning curve is dentists are going to be transitioning from a tactile feedback, right? You know what enamel density feels like, visual and also audible. And when he talked about that plume, that's going to be one of your key indicators. When he's in enamel, it's going to be that little ball of light, right? It looks and sounds a certain way. And he's going to know, I'm in enamel, I got to give it more power, right? But as soon as he gets into the dentin, it's softer, more water, that plume turns into like the sparkle. But as soon as he sees that, he knows, oh, I'm in dentin. I don't need as much power. He's actually going to back off. Like going from the freeway, now I'm getting off, he's going to back off on the foot pedal. And then when he hits that decay and that plume goes away, back off even further. So he's backing off as he's getting into the tooth. And then if he's like, oh, I'm going to come up on my margins and I want to bevel them, or I need to remove a little bit more power, it's going to get back into it. So it's It's really modulating that foot pedal, but you're visually seeing, you're getting these visual cues on what type of tissue that you're in. And quite frankly, that wasn't by design. That just happened by accident. And it was a blessing because if we didn't have those visual cues, it'd be really hard to understand where we're at in the tooth and how to modulate.
Right. And this is why I saw some of you brought loops. I don't think loops are a have to, but it does help to really see that on a zoomed in level, that ablation that he's talking about happening. And then it's literally like you're just watching it just crumble away. Kind of like we just saw, right? So it's pretty cool. Yeah.
Don't use a spoon or.
So
Do you?
absolutely. Yeah. So here's the last part before, and then we have, by the way, we have some other stuff on like ROI, like business coaching and stuff. I'm going to kind of skip past that, but if you can imagine starting to look at like, oh, this creates efficiency. I'm adding procedures like what's an average crown lengthening fee in the Bay Area? Probably at least, yeah. That now, not that we're not going to continue to use our great specialists, but now some of those cases that you can handle in your office that I'll show you, let's call it 1,200 a case. Do 2 of those a month and you made your payment, right? So that's a whole section that I'm going to skip at, but I do want you to kind of think about as we add these things, these are procedures we're adding, we're creating efficiencies, we're creating a great patient experience, right? But because we have limited time, I'm going to launch into all kinds of fun clinical stuff. Now, why doesn't it hurt, right? Why can I use a spoon? This is a raw, open gum line, ouch, right? So one of the things that's happening under the hood is that 1,100 times a second is creating sort of, it's not something the patient perceives, but it's creating a vibration effect that essentially is creating a stronger stimulus that kind of overwhelms the pulp tissue. This is back to that pain gate theory from dental school that I forgot about until we started using lasers. But it's creating such an overwhelming stimulus that then when a painful stimulus wants to get through, my spoon, a round burr, air, water, it's a traffic jam in the pulp tissue, right? So I have 7 or 8 minutes to clean it up with a spoon if I want to. I'm just more comfortable with that a lot of times. It is absolutely in my kit. I can pull out a handpiece and like straighten up the walls of a class 2. I got to blow air on it, right? Because I got to dry it to do my bonding steps. Totally fine, right? So why doesn't it hurt? Analgesic effect that we just described, that's a huge part of it. Second thing, when we go to cut, I'm not going to have you cut teeth with the quarter round burr. I'm going to have you cut with the big old 1.25, 1.5 spot sizes because those cut better. But also that bouncing the beam around with the galvos, it never hits the same point before hitting all the other points. So you don't get a buildup of energy in one spot, which can create sensitivity, right? Third reason doesn't hurt is it's so highly absorbed in hydroxyapatite, it's only going 2 microns into tooth structure before it encounters something that it needs to cut, right? So it's just so absorbed on the surface, a lot of that signal just doesn't get in, right? So, but it's the analgesic effect why you can do all that. And that goes back to what we were talking about too, right? I use my handpiece all the time, right? I don't need to for a class 2, but I'll do 90% bulk reduction with the laser and then break the contact with like a flame diamond and I'm done, right? And decay removal with the laser and everything else, right? So yeah, so part of, and this is the studies that I made for, I'm like, if you guys have studies, I want to see them before I bought. They had to show it wasn't heating the pulpal tissue or altering that. If anything, they showed a cooling effect because there is water spraying down. So anything it showed, so literally they had to do an experiment where they had a tooth, put a temperature probe through the pulp canal into the pulp chamber and then fire the laser and compare that with the drill to even get FDA approval. But a note on that, like studies that are now out there is that also for bonding, UCSF, any UCSF people there? So you guys know Peter Rushman? He's done a bunch of studies up there with John Featherstone. You guys know John Featherstone, right? He basically invented this thing. So, but he's done studies on drill versus laser and like total etch, partial etch, self-etching primers, and showed that we're not like cooking collagen, we're not collapsing pulp chambers, we're not, you know, the conclusion of that is whatever glue you're using now is fine. It's not, if anything, there's no smear layer to deal with though, right? Because you're not whipping tissue around. Yeah. I will say, kind of adding to that, anytime, let's say I have to cut off a gold crown, I can't do that with the laser, so I'm going to numb it. And oh, I'm near the pulp, I'm going to pull the laser out. Because I know what we just talked about tissue selective ablation. I know I could be extremely careful about removing that tissue, the decay. And if I do get a little pinpoint exposure, I just lasered that, not round burr whipping debris and decay and bacteria into that pulp exposure, right? So it's just a better, more specific tool that I almost prefer to use it if I'm close to the nerve. Yeah. Yeah, thanks for that. Okay, so let's do that. So let's get into let's get into how to prep here. I'm just skipping past a couple things for us. Okay. We talked about this a little bit, and this is kind of our little tutorial too when we get to prep on our own. By the way, how are you guys doing? Anyone need a little break, grab some more food, coffee, or anything, or just keep rolling? All right, I love it. Okay, so end cutting, right? We're going to point it at the tooth, dissolve it away. In this case, though, when you do a class 1, what I was taught was extension for prevention, right? Stick the burr in there, move it sideways, knock all the grooves out, right? Whether they're decayed or not, because you don't want to have to come back later, right? Don't do that anymore, right? Like even if you're not lasering, I would, let's say you had a whole molar and just in the distal fossa, there's decay and the rest of the grooves appear to be fine. Maybe you're doing a little PRR there, but just treat the decay and then seal the rest. Same with the laser, right? But with the laser, I don't start right in the groove because if I go right down in that groove, I don't have any way to expand the prep. So the way we think about it is more of a top-down approach. If here's the decay I'm going to work on, I'm going to basically start lasering away, end cutting, end diamond, right? I'm going to laser away one whole layer and then do another layer and then do another layer. And so your prep just kind of sinks down into the tooth like an elevator, right? And that's how you do it even faster. And all that enamel time of cutting enamel gives you a good analgesic effect, right? So it's all built into that process. Like sometimes people, well, what do I got to do to get that analgesic effect? Just cut it and it's going to create it, right? Just start working on the tooth. So that's the technique, top down. And then now that I have this hole, now I can go in there and let's say I want to move my prep over. I want to expand the preparation out. I can just take that laser, end cutting, right? Where it's normally pointed right at the tooth and turn it sideways, even 90 degrees, and just point the laser at that wall and move that wall over as it goes, right? So I'm changing my angle depending on where I want to cut. Let's say I'm going to drop into a class 2 and I want to move that buccal wall over, laser, laser, laser. Now I'm going to open up the lingual wall a little bit, laser, laser, laser. So I'm doing wrist changes the whole time, okay? Distance then, you're about 10 millimeters away, and then the slower you move your hand, it's almost like awkwardly slow, and then you'll see it cuts like crazy, right? So if we're moving really fast, it's going to cut, but it's not going to hit those layers efficiently. So slow your hand down while you're cutting. Okay, so let's look at an example of that. Great example here where you have that kind of fluoride decay. It's a little pit of an opening, but it really expands out and underneath there. So I'm going to angle over and start removing that occlusal enamel. You can start to see where that affected DEJ, that little decalcified DEJ is. So keep moving, expanding your prep past that. And where you see that darker decay. And I'm kind of constantly changing my angle to try to widen that prep out. Right, and angle it left and right. You can see it, how it's that bright plume. By the way, when we go to cut on the extracted teeth, some of these teeth are more than 6 months to a year old. And so they are a little dehydrated, so they don't cut as efficiently. So just a side note while I'm thinking about it, we'll remind you of this too. Instead of cutting at 30, we'll probably cut at like 60 or 70 to give you more of an idea of what intraoral cutting looks like. So increase the power a little bit, but it does make the plume a little brighter when we do that. So the plume you see today is not what you're going to ever see in the mouth when we go to cut. All right, so I'm just kind of moving along. And I can see down in there, there's that little sparkle. So in the video, it looks a little darker. It's not decay left. I'm looking for that little plume off of healthy dentin. That's how I know I have all the decay. Now, spoon, round bird, 1558, whatever you want to use, absolutely go in there and do a little cleanup. Or if I want to just use it to widen out that prep a little bit, I can do that. All right. Yeah. Yeah. So the place where the beam comes out on either side is a water spray that is spraying down onto the tooth. They're two mist nozzles that basically converge at about 10 millimeters down. So it's kind of that perfect spot for it. So why the water? It's helping kind of wash away ablated tooth product to expose more. And then there's a cooling effect as well from that. All right, and then restored. All right, now this video wasn't playing very well, so I apologize for that one. There's 2 videos when I transferred this over. My computer finally died after 10 years, so I got a new one, and I don't know, codecs or something. Okay, one question that comes up though, what about the wedge? What about a matrix band? They're not numb. It's really great because now I don't have to have them back for a second visit to adjust, but how do I stick all that stuff on there? Rubber dam. Well, if you're using a rubber dam, use a non-engaging clamp or just use a little wedge, like a corner to lock it down. With the matrix band, I use curved, like a paladent style, like a curved anatomic matrix band. So that slips in there really nicely. That's not a problem. But sometimes the wedge is, and there's a couple of ways we could do it. One is just go slower, right? When I'm displacing tissue slowly, then the gums will kind of memory foam move out of the way. We have done it with a little topical. I've also done this, where you just kind of blunt that little peak of tissue to create a little triangle space for that wedge to go in there. That is going to grow back in a half a day, right? From doing that, but it's just wherever you need it. You could do a little blunting there. But another hard tissue video for you here. In this case, we're right adjacent to a porcelain bridge. Sometimes the question I get is, well, what happens if you get close to another tooth or close to the gum tissue? It's that 1.25 millimeter spot size does 0 cutting 0.1 millimeters to the left of it, right? You're not spraying energy. It's a very focused beam, right? So I don't have any problem not touching. So I don't if I'm doing a class 2, I don't have to stick anything between the teeth, so I don't blast the other tooth, right? And then you just kind of go in there and remove that decay, wherever that happens to be. Part of that is an old composite. One of the things you can see there is when we talk about doing class 3s, class 4s like this, is being careful where that beam is pointed. Like if you're doing a class 2 on a molar and you're cutting, what's on the other side of that cut is just more molar. But when you're cutting a class 3, on the other side of that is air, right? So we cut the suction just behind it. So the suction stops the beam from hitting the tongue or anything like that.
Was it not, affecting the brain?
It's just that controlled of power. Now I can't, I mean, I could very easily just turn it and it's absolutely going to cut it, but it just does, it's weird. It's almost like moving a spotlight around, and wherever that spotlight is where it cuts. Yeah. But here's the cool thing too. I actually think this is safer than a traditional handpiece, right? Because remember a couple things. Remember we were talking about technique. I have to hold it there to cut. So if someone swallows and I accidentally glance it against the interproximal surface of the tooth next door, it might not even be all, 46 points of the 1.25 pattern. Might be one part of the beam hits it. And unless I hold it there, all you're going to see is what looks like a phosphoric acid etching, if you even see that. Now, if I want to really cut that, I hold it there and then it'll cut like crazy, but I got to let the energy do it. Let's say they swallowed and then you kind of went over on the gum tissue. You'll see a little almost de-epithelialization happen. Take your foot off the pedal, but that's all it's going to do. Versus if that's your burr, you just cut a defect into that gum or tongue, right? In fact, in just a little bit, I'm going to show you a frenectomy where, and not intentionally, the frenum was so thin that part of the beam went and hit the base of the tongue. And by the end of the 9-second video, you can't even tell because we didn't hold it there, right? So I'll make sure I point that out
But
with there.
Sometimes when you mallet, might face a section of matrix.
Of course. Yeah, especially if they're like that in the front
What does laser do to that?
to the band, it'll mildly reflect off of it. Yeah, the plastic one, it'll cut it. Like if you do a clear one, that's not going to stop the beam. Weirdly enough, isolite won't cut. I haven't looked into what isolite is actually made out of, but I've tried lasering right on it, and it just kind of makes almost like a little scoring mark, but it doesn't really cut it. So that's a good way to do it. No.
At the, say on the base, or I mean at the cervical margin, you were prepping the tooth, it would cut the wood, right?
Yeah. I mean, essentially, it would.
Is there that hole there about 10 millimeters?
About 10
away
millimeters
from
away.
the cell?
Yes.
And is there a depth that it would cut regardless, or is it just based on the tooth structure, then the type of tooth structure?
So cutting depth and speed is based on power, yes, and density of the tooth structure. So it'll cut dentin at the same power faster than enamel, but it'll cut at 20 millimeters away. It's just not as efficient. You know what I mean? It's like, yes, as I'm cutting a class 2, I am kind of lowering it in, but if I'm not, it'll still cut down in there. So it'll remove decay at 20 millimeters away, no problem. Soft tissue, I can be 5 to 40 and it's still going to cut it. But the difference is if I'm 30 millimeters away, it's still hypercollimated. It's not spreading like if I get farther away with conventional CO2, it would make that beam bigger and bigger and bigger. If I'm 30 millimeters away, it's still 1.25. Yeah. So that's partially how we control the adjacent tissue, right? Okay. I love this case because it just kind of shows how deep it goes. Side note, just in case you see it, this is the straight handpiece. difference with the straight handpiece and the contra angle handpiece is just one bounces the beam down for better access. It's more about where you're pointing it. There's nothing special about the laser firing differently. It's still 9.3 micron beam, but I did want to point that out. The reason I love this case is it shows how by the time we get to the end, you'll see secondary dentin. We're so deep in there. You see kind of that scarring, healing dentin where the pulp tissue used to be. That's how deep we are. So this kind of gets back to her question. You know, like what if it is a deep prep? What if it's close to the nerve? That doesn't change our technique. You just laser longer, right? I have no problem doing this on deeper preps. The technique though is still the same in that way, that open the enamel up, right? Get it to where you can see everything. Then you can go ahead and laser everything after that. Yeah. Some soft tissue things the water's off, but back to that kind of cooling effect. And if you're not using water, what it'll create is like a little layer of, it's called recast, where you just kind of have like it ablated everything and it all kind of sits on the surface like just this schmutzy layer, and then it doesn't cut that. It just kind of continually just melts that layer. Think like melted enamel, not ablated enamel. So the water is helping get it out of the way. But to give you an idea, I mean, that like on that setting, it's 8 or 9 milliliters per minute. Our handpieces do like 50 or 60, to kind of give you an idea of like what's actually coming out of the hand, you know, the handpiece itself. So it is more of a mist than a like a spray in that way. Yeah. And then restore it. Cool. But you can see where someone asked, I can't remember, someone asked like, oh, can I use a spoon? In this case, I'm just using my Explorer to feel down in there and kind of check, but like all day long, right? They're not going to feel that. They'll feel the touch, right? But they just won't create, we won't trigger sensitivity from doing that. Okay, a couple more cases, then we'll get into some soft tissue stuff. Oh, I just added this one. So I mentioned in Walnut Creek, we got to do this event where we did some live dentistry stuff. So you got to watch, and they had a camera being, you know, shown into the room of, we did a mucus seal and pronectomy and all these things. Super fun. This is the patient that I just know her. So we flew her up from Santa Barbara and we did other cavities, but this was a couple weeks before that. So you got to see like, I thought she would be a good patient because these aren't small cavities, right? Now, so all these class 5s, and I'll show you all of them that we do, and then kind of just I'll kind of keep an idea of time while the video is playing. But all these class 5s, not a great brusher, right? And that's one of the things we're working on. But when she did come in, what you'll see is the tissue looks all red and puffy, because when she finally came in to do these after we diagnosed them last fall, and she's like, oh, I better brush. Jeff's going to work on my teeth. And went right before we took this video. So when you notice the tissue bleeding a little bit, that's what it's from. And you'll see it looks inflamed anyway. All right. So have some deeper. This is where your Explorer or your spoon would just, I mean, it's just super soft decay, right? All right, so I didn't do this last time and I wanted to, but I'm gonna add. All right, stopwatch. 1.25 setting. I think my governor's at 30, so I'm at probably 10, 20, like halfway down the foot pedal-ish. Removing all that decay. again, this is where you also change your angulation too, where now I want to get to that stuff. So I'm going to come around and move the beam so it's pointed down at that decay on that side. Right? And kind of clean all that up in there.
You have to be getting some tissue at the same
I might in that case, especially when it's so hyperplastic. Yeah. Yeah. But you can even see like, and then jumping the video over where just the gum already started pretty red, you know. So it's
You've been doing this a long time. How often do you do you find that you change the handle a lot at your level now?
change that.
The handle.
I mean, from like a straight
Yeah.
to, you know, yeah. So I would say 95% of the time I'm just using contra angle for everything. Yeah. I mean, it just kind of depends on like, oh, I'm just having trouble angling this in there. Get this straight up. Yeah. 1.25 millimeters. Yeah. Right. Kind of cleaning all that up. And one of the things I was doing there too is just testing how hard that was. Again, back to that tissue selective ablation. I can run it over that tissue, and if it's a pretty decent plume, it might be more affected than infected. Remember that whole thing? So now you can see where it's just starting to ooze because everything was so inflamed a little bit there. Right, and then finish up on that canine there. So 3 decent sized prep, 1 more of a smaller prep. I'm at 2 minutes 35 seconds. Let's add another 15 seconds because I didn't start it on time. With the laser, same, you might get a little tissue mark, not a deepening cut, you know,
Right.
like a little white spot that as soon as you put moisture on it goes away. The other thing too is you know, this thing's going the speed of light, right? So if I take my foot off the foot pedal, that beam is essentially stopped. Like our electric handpieces running 200,000 RPM are still after 1 second, maybe still going 50,000, right? I mean, they're still spinning and has the potential to cause injury that way, right? Oh, sorry. So about 3 minutes, 15 seconds for the preparations, right? No numbing. And that's where we didn't have to necessarily stop with the bleeding. A case like this, I will say sometimes I have to pull out a little viscostat, or, you know, just because it's like just a mess. This laser is really good at cutting with no bleeding, but when you have just this puffy mess, like MO on 19 and it fell out 3 months ago and they've been packing food in there for 3 months and it's super puffy and red, I might cut back some of that sculpted tissue, that messy tissue a little bit from that. But some of those blood vessels are so swollen in the edematous that there's not enough collagen to contract to shut it down. But that's where sometimes if I could just get that puffy gross layer back, then that'll stop it too. But I'm trying to be lower impact on here. So again, just kind of thinking about efficiency then. So 4 preps, 3.5 minutes, not multiple numbing sites, right? Finish that up. Now it's right, more efficient. Okay. Just for time, I'm going to jump to when we start lasering here. So class 2. I have, I think 2 more cases to show you, and then we'll, yeah, 2, this one and 1 more, and then we'll move on to some surgery stuff. So top down, right? End cutting, start to do the class 2. Class 2 is almost more like you're doing almost kind of a triangular prep first, just across that whole surface. And then you'll see where you start to drop that in there. And absolutely, you'll see the rate pick up when you get into softer decay. All of a sudden, whoop, it'll open up, right? And all of a sudden, you kind of see that. All of a sudden, it went from like there's still a little bit of a layer. You guys ever feel that even just with your burr, like you're dropping in, and all of a sudden, whoa, like the laser energy will flow the same way. And then angle to hit that lingual wall, angle to hit the buccal wall. Now, at this point, you see there's a little decay left there. So what I'm gonna do is my favorite burr is a 1558. It's a column fissure burr, cross cut with a round end to it. So it's tall, so I could hit that whole buccal wall at the same time, right? So that's it right there. And now that analgesic effect is so profound, I can literally polish away that decay. And that analgesic effect in pediatric teeth is like crazy. So whereas with adult teeth, I'd say we're 90 to 95% anesthesia free, pediatric teeth is 100. It's just, I don't know, we haven't figured out what it is, but the analgesic effect is just so profound that we could do this all day long. Let's say there was a pulp exposure and you're gonna do like a pulp and crown. So I'd come out and I'd start nailing all the cuss tips, dropping that whole top down, and I'll pull the 1558 out and zip the lid off the pulp chamber and then laser everything out. No more formal cresol. The laser's taking care of all that, right? And then do your restoration.
Are you purposely using the plastic instruments, or is it?
Oh, like the mirror? Oh, so we only, and this is the idea I got from like the guy when I bought in with the guy who owned the practice. He always used plastic just in case it clacks against other teeth. But you don't necessarily have to use it for the laser at all. It's not gonna, like, you won't accidentally point it at the mirror and then have it bounce somewhere else. And yeah. It's more of like if you happen to ding teeth, it's not metal. That's why he did it. I'm like, oh, that's a great idea.
What happens if you use metal? I use the rubber band.
You'll get a little reflection. Same, and I'll talk about this when we talk about implant uncovery. Like it'll hit the metal and bounce off, but it's not super shiny and it's not polished the way these turning mirrors are. So it's not going to be an efficient bounce. It'll more like refract, which breaks the beam up, but also we're spraying water down. So let's say I'm doing an implant uncovery and I'm going through tissue. At some point, there's that healing cap down below there. So I'll get a little reflection off of that, but that's when we keep the water going, because as the water is spraying down, that's kind of catching any reflection coming up. And then, but as soon as I see that healing cap, I'll move on. But it's not going to arc or spark that metal at all. So the corollary to that is, well, what about that braces case I described? And I'm going to sculpt tissue around braces. If part of the beam hits that metal, just be aware, don't hold it there, but it's not going to blow the bracket off the tooth or anything. Like zero. Yeah, you'll just see it. In fact, we use this on peri-implantitis, right? So let's say you have a kind of a facial dehiscence of an anterior implant. You can reflect that back and then literally point right at the implant and ablate granulation tissue right off the surface of that implant. It's non-cutting, right? Or non-contact. And then, and you have probably some techniques like this too, where then I'll punch holes in the bone to induce bleeding, put my bone graft on top of that, put a little membrane over, and then close the whole thing up. But I can, the term that this periodontist Scott Fromm, have you heard of him? He uses the term detoxify, but he's nailing that implant and then holding the suction right above it in case any reflection comes up. So you're being careful, but that's how we use it for that. Yeah. Okay, last hard tissue case, and then I'll show you So this case, I just love because, just to skip through this, so she's in her later 40s, has had these discolored composites since she got her braces off in her teens. And it's just kind of like this, oh, I'm not going to be starring in any movies. They're fine. I'm like, well, they are fine. There's no decay around these composites as much as they look terrible. I didn't tell her they looked terrible. I said, but you could tell with patients when they just don't smile either. They're smiling like this. I'm like, and talking to her, figure out, well, she won't do it because she's had so many terrible experiences with dentistry that she actually has gotten to a point where she's like, I'll live with it because I'm so terrified of getting this. I don't want to have this numb, right? And I don't want to have, the drill and my front teeth and all this kind of stuff. I'm like, well, how about we'll just laser it? And we just did part of one. And then she's like, oh, that's it. By the time we were done, she was asking to redo this one, right? So this ushered in a way for her to actually get dentistry done, and it changed the way she even smiled, right? I mean, this is that kind of one of those components we talked about of the 4 things was patient impact. Like if I don't have to numb or drill on someone, and when I say numb or drill, we talk about that, right? I got to finish this composite with something. But I'll tell her like words like, we're just going to polish this. Her vision of drilling on the tooth was 30 minutes of grinding on her head, right? Not, I'm going to do a light surface polish to clean up that composite at the end. Because with the laser, you're not feeling anything, right? As far as that goes. All right. You guys, so many good questions. So any questions on that before we jump into some soft tissue surgery fun? Yeah.
So I know you gave us 4 things that it cuts, so it doesn't cut metal, right? So if we had an amalgam filling, say, you could repair the margin, and you wanted to just cut around an area of the amalgam filling and fill, are you able to do that?
Oh, totally. Actually, let me show you. Yeah, let me show you one slide here. Okay. So you can also use it for removing amalgam, but absolutely if you just had a little area adjacent to it. Weirdly enough, it does kind of partially ablate amalgam. Like it's not efficient, but it kind of almost like etches it and kind of chunks little pieces off. Maybe it's the water effect, but wait a second. Yeah, it's probably partially doing that but from the water component side. But we also worry we're aerosolizing mercury. So as a general rule, we just have kind of said, well, until we figure this out, let's just not. But I can trough around areas of leakage, create an analgesic effect, and then just drill that thing out. And absolutely, if like you wanted to stop somewhere like right over here and kind of in this area, just kind of, and then just repair that. Because as you get in there, you're like, oh, this isn't decaying. It's fine. I'm just trying to all day long. That's clinical judgment, but can the laser do it? Totally. Yeah.
So that can remove the amalgam.
So but then at this point, I'll take a burr and go, and that's when I'll go tell the patient too, hey, by the way, when I get to this part, you're going to feel some vibration. Yeah. Not from the laser. Yeah. So all this scene here in this one has so far been all laser. Right. Well, you're not going to feel cutting that amalgam anyway. I mean, you'll feel vibration, but you're not going to get sensitivity from cutting the amalgam because the water spray is taken care of by the analgesic effect. But then that's why I'll still do a light touch, and I can get, like in this case, I can get away with, I would keep going with the burr like all down in there, right on the tooth, because it just like in that pedo class 2, I can keep going, right? And then the last touch of the tooth is a laser because I want that antibacterial component too. Yeah. So yeah. Nope, not once you get started. Now, sometimes when I'm first getting going, people are like, oh, my tooth's cold sensitive, right? So let's talk about, like, I said 90% anesthesia free. What's the 10%? Like, when is this not working for stuff like this? You know, you just have, some people just have sensitive teeth. And I don't mean you can't use this on people with sensitive teeth, but like if I'm doing a class 5 and they're like, oh, there's water, that like my teeth are really sensitive, I'll just do like 2 seconds and they go, how long is this going to take? I go, oh, it'll be like a minute, you know. And some people be like, that's fine, you know, I could do this for a minute. And weirdly enough, like a comment I hear not daily, but many times a month is, you know, the weird thing is as you were lasering, that cold sensitivity, it stopped bothering me, it went away. Well, what's happening there? That's the analgesic effect, right? Now, some patients, I do 2 seconds and they're like, I can't do that. It's not the laser, it's the water, right? And in that case, we'll do some numbing and we'll still use the laser because it's arguably a better experience because you're not drilling and grinding on the tooth. 6-year-old with a hypoplastic first molar where the enamel didn't form right and super sensitive to cold. It's going to be really hard to laser on that if you can't even put water on it. So I'll numb it up and then still laser it, you know, again, for that experience. And those parents are still over the moon too, over the whole thing, right? So that's the 10%. It's just, some people are just hypersensitive. The redhead thing is a very real thing, right? That's my sister-in-law is a redhead. That was fun. You got to try this laser. It's awesome. No, 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 no. I don't have to numb it up. And it was so sensitive. Like, I'm like, sorry. But she still thought it was okay. It just was like it's the feeling that if someone's going to be sensitive is not like you drilled on the tooth with no numbing. It's kind of like, oh, that's cold, twingy is the feeling they get if they're going to feel anything, right? 90% of everyone else, no problem. And that's why we don't have a clarification in our office for like, oh, you kind of look like a laser patient, but you don't, you know, it's like everyone, we're using that. I mean, yeah. Okay. So thanks for that amalgam question. So we have about, how you guys doing, by the way? Keep going? Keep rocking and rolling? We'll take a little break as we go to work on the things, but that'll be about 11:30. So we have about 45 minutes left or so. Is that cool? All right. So laser teeth, awesome, right? The stuff I'm more excited about is not this. It's the 84 other CDT codes that you could do with it. Like for us, we just weren't doing a lot of things like crown lengthening and frenectomies and fibromas and all, right? Implants and all these things that we now use it for. We do flapped traditional perio surgery with it, right? I mean, there's all these things that we do. So for me, this is like the awesome part because this is what really helped me grow as a clinician from more straightforward things to now adding in this whole dimension of stuff and also kind of knowing when I need to send it to you also, right? Not to get in too much into the weeds, but you start to look at all these other things, you know, and I have a list. Let me jump ahead a little bit. This is just like a partial list of some of these things that we can do, right? You know, wedge procedures, crown lengthening, you know, operculectomy all day long, right? I got a 13-year-old comes in, and I have this on the video too. It's not in the presentation though. 1831 operculectomy kind of case where the tissue's grown halfway over those back teeth, and there's decay already starting on the grooves. So how was I doing that before? Step one, refer, because I'm not doing that on a 13-year-old, right? Then they come back after healing for a few weeks. Now are you gonna do a double IA block? So you probably do one, right? And then do the one next time. And now that person's really stoked to come back because it's like the third procedure in a month. So now I'll use a little topical, and when I say topical, not benzocaine. Anytime we talk about topical on this next little segment here, it's compounded topical. So like ours is lidocaine, tetracaine, phenylephrine. It's just it needs to be a little stronger, something that's going to penetrate in more. But I'll put a little topical under that operculum and then a little over the top, let that sit for a minute, wash it off, and just laser sculpt that tissue back. Then point it down at the tooth and step harder on the foot pedal, remove the decay, move on to the next side, right? They might feel a little pinch on there. And that's why I kind of go, my rule of thumb is the deeper we go, the more, someone has poor denture extensions in the maxilla, I can go and do a vestibuloplasty, or imagine cutting into that vestibule and making it like where you would border mold, make that deeper. Actually, I think I did add a case where we do something with that. That, you got to numb up for that. Yeah, yeah. Extraction for a tooth and using it with that. Implant where we're going to do a crestal incision and open things up. But a lot of our implant procedures now are all guided surgery, and we just hole punch with the laser. And then that's healed in like a day. So I think I have a case like that I threw in there too. Okay. Before we get into that, I wanted to show you this really disgusting video. So what this is the floor of the mouth of a pig jaw. When you come to training and we teach you in more granular detail about the laser and how to use it, like super granular, how to prep, how to do a class 2. We also do soft tissue procedures where we'll like do a gingivectomy and a crown lengthening, and we teach you how to actually do all those procedures. And this pig jaw is great because it cuts like that, and you cut around, there's actually teeth to cut around, right? Well, the floor of the mouth was starting to kind of dehydrate as we were sitting there. I mean, these were like, I don't know, chopped up. I don't know what they do with these, but then they freeze them and they send it to us for the class, right? And this was starting to get a little loose. And there is a mode where you can turn the water off. And that's where we do things like de-epithelialization, like aphthous ulcer, lichen planus, where you're just creating almost like a laser Band-Aid and removing just that top layer of tissue. So I was showing them that, and I noticed this effect that was happening as the collagen shrinking, it's shrinking into that laser area. This is why it doesn't bleed. This is how snoring works. You won't see this effect when you're doing the snoring treatment. It's only because this tissue is a little looser. But here's what it actually looks like, right? So as you're going along, this is why it doesn't bleed. It's actually shrinking those down, right? And look how far away you're seeing that effect happen, right? So again, when we start to look at kind of like, well, why is this thing working so well? This is what it's actually doing, all right? So let's look at some easy cases here. So this is a gingivectomy where this was going to be a veneer case. This case we actually did in this live dentistry form. Is super nerve-wracking, but super fun because we did this in front of 400 people in the audience. It's like, man, I hope this works. So you can see where I just used Sharpie basically to outline kind of where I kind of wanted to go. And then watch how it just kind of paints that tissue away. This is where the straight hand piece is great because you're just arcing across there, right? And I'm just going to kind of peel that back. As you go through, some of that deeper tissue layer is a little thicker. Side note, I think you were asking about this, like about the heights. The bone is about 4 millimeters back on this case. We stopped sounding and we measure more on a CT scan now because it's just, so we kind of scout that first. But that's how I know it's not going to grow back. And then moving on to the next one. I think I get my fat fingers out of the way here at some point. So most of the videos I've shown you are shot through a microscope in my office. This was just from overhead cameras. So that's why it looks like it's a little in the way, but just paint it away. 1.25 spot size, right? And just paint. Yeah. Like if here's the tooth, I'm kind of coming at the gum like that. Yeah. So that it'll, if anything, it's just, if I do happen to hit part of the tooth, it's hitting it more of like a glance. And so the other thing too is, right, those roots are more like this. Those front teeth aren't necessarily straight. You have some angulation back to the maxilla. So that's kind of what I'm taking advantage of a little bit too. Right? So that's how much bleeding to expect, right? In healthy tissue, not like my friend who was struggling with brushing. Okay, let me show you another one where we do an example of a gingivectomy. I pulled this out of another course we do on aesthetics for you guys because I wanted to show you this today because this kind of shows a little bit of that. So immediate post-op from braces, you can see where there's kind of like a bulbous tissue in there. There's a lip tie that's as far back as you could pull her lip because it was tied in. And you can see where there's an obvious tooth size discrepancy, and the height of the contour of the gum of the papilla comes all the way down to there. Well, what's the problem? So now we're going to do some bonding, right? Orthodontist is done. We're going to make retainers. You go over to Jeff and he's going to do some bonding. So the problem is if we start and, we want to, first create a little bit of a change in the height, right, to allow us to improve on that height width ratio, because if I just start here and add composite, I just made a square looking tooth. So I want to also, as I increase width, I want to increase a little height. Concept number one, and that will go into more detail when you come to this class someday. Concept number two is I don't want to, oh, actually right where I left the arrow, you see right here, if I start my composite there, it's going to look like a little hip off the side, right? So where that blue line is, that's where I'm going to start my composite. And BioClear has some interesting matrices, right, that you can kind of get up in there and push that tissue out of the way. But I didn't want it to come back either. I didn't want to crowd. So how do I make it so my height of contour starts higher up the tooth and does a nice long arc down, right? So that's kind of what we ended up doing was, number one, lasering that tissue back and doing the frenectomy all at the same time. The code for this is excision of hyperplastic tissue. 7970, D7970, or 1, right? We don't use gingivectomy code because no one pays for it. But so we did the frenectomy, then recontoured the tissue and brought the height of everything up so we can start adding composite. And then the technique then is I'll add to 8 and 9, and then I'll build out 7 and 10, and then do the distal 7 and 10, and then build out 6 and 11, and kind of split the difference every time. So I'll build out the composite here, and then just use that little Teflon tape. You guys use that too? The little plumber's tape. Wrap it, and then build right up to it with that side, and then do the other side, and then build up 6. And then, so now we can, and then this is immediately after that. So the only reason I feel like we can do that, you still see the laser effect, right? But the only reason we can get away with that is because there's no bleeding, right? Versus, and from the gingivectomy part, she's going to be healed in about 48 hours. Done. It's like done healing, right? We let her know, oh, it's going to be like you had a little pizza that was too hot for a day. That's it, right? With this case, I would have used just a little topical. Just smear it across that gingiva so that there's a little bit more comfort, so they just don't feel. I think you were asking, like, it's like a little pinch, but it's not like you're cutting their gums, right? But I would add that in there. All right. So we're able to take in about a half an hour, go from that to that. Again, back to efficiency. I have a frenectomy code, whatever you want to charge for that. Should be at least $650. And not to talk about money in this, but this is how it's benefiting your practice too, right? Is I'm getting this very efficient laser procedure done. You're getting compensation for it. Everybody wins, but you're using this great tool. So the healing's like the story continues, right? Of those 4 things. Excision of hyperplastic tissue, and then 6 composites. 45-minute appointment, right? No numbing. Now, I know you guys wouldn't have numbed for that composites anyway. I just mean you made it easier to do, right? Cool. Couple of the cases here, broken veneer, and then the tissue's already grown over that. And maybe you're just doing a quick repair. Well, why not? And by the way, just to call it out, this is another trainer, Dr. Josh Weintraub. This is his case that we stole from him. But I'll move that tissue back so that it makes it easier to then do a repair in the moment and or go to the final restoration, which is what he did with his CEREC, right? And then made both gum heights the same in that case. So very versatile. I can't tell you how many times, oh, let me back, I don't want to show you that one yet. I can't tell you how many times the tissue's in the way of a good restoration, right? And I think there's times where I would stretch it and do like a little burrectomy. And just kind of get in there, like distal of 19, just get in there, right? Versus now you have a tool that will efficiently cut, potentially has billable procedures. And I don't, just like those class 5s where I move the gum tissue, I don't charge for that. That was more for me to have a better capacity to get in there. But if you have a margin that like mesiolingual of 19 and that cusp broke down below the gum line and you're right by bone, you're going to either do a burrectomy or you're going to create a biologic width issue and have inflammation for the next 2 years until that bone remodels. And now you can remove it, right, on site. Okay, I'll hit play again. Watch right here. I think I was alluding to this video earlier where just for a second it overshoots, and then watch the frenectomy, but watch that little dot too. Yeah, just barely overshot. Now frenectomy, he keeps going. You're putting tension on those fibers. And that's it, right? Why I love all these other CDT codes over just class 1s, this does so much more than just, this is not a tooth prep machine. This is this all day long and a million other things, right? So now you, and here's what I was gonna say, you can't, Dr. Kotlow didn't just hold it there. He kept moving, right? Worked on the front, where did he hit it, right? You almost can't even tell where, right? So in that case then, you got, pretty decent blood vessels right there. So the safety, if you haven't done this before, like I didn't, just basically stay in the middle, right? You're just staying, just don't go over, don't go over here where there's a lingual nerve, lingual artery, all that, right? Just stay right in the middle and you'll be in safe territory. But basically the technique is pointing at it and it's gonna cut. Here's another one, maxillary one, where definitely talk to your orthodontist about this, because what I've seen is in this area, what they'll do is they'll just smash 8 and 9 back together with brackets, which pinches that tissue. And then they have like a month where they have just like a facial and lingual swelling off of that pinched papilla. So laser it away first, then close it. And the patient will be in much more comfort. Side note, this patient's numb. Right. Again, this is Dr. Kotlow. He practices in Albany, New York. He pretty much wrote the book on pediatric laser dentistry. Have you heard of Dr. Larry Kotlow before? He has this class on tethered oral tissues that talks a lot into greater detail on this. So again, back to resources if you want to get into this. Infant tongue tie, right? You know what the standard, like in maybe it's more progressive here. The standard of care in Santa Barbara for a tongue-tied infant is scissors. ENT comes in, snip, bleeding, pain, inflammation, right? compared to laser dentistry. So our pediatric specialist that works with us, she'll get kids that are 2, 3 days old. They have these cute little like swim goggle eye protection, right? They're swaddled up so they're comfortable. And then, oh, so there is a water off setting for that too, because you don't want the water spraying on like, and then they react, right? So basically it's no air, no water, just a nice, tight, hot laser, and just it's a 7-second frenectomy. There's no bleeding, and they're healed in like 48 hours, right? Compare that to a scissor, right? So I personally haven't gotten into that part. She's amazing at it, so I don't know if I could do a frenectomy on a 2-day-old, but she's pretty awesome at it. But this is where we start to see that benefit. Part of it is like, I just don't see very much of this. Like, when am I gonna do this, right? Well, you know, I didn't see it either until I started having a tool that allowed me to do it, and then all of a sudden, you start to notice these cases come up, right? No, we don't do a frenectomy every day, right? But a couple times a month, we'll see a case that truly needs it. This, back to that integrity piece, this laser isn't about, I'm just looking where we're going to start here. This laser is not about finding a bunch of dentistry to pay for itself, right? This is the fact that the dentistry is often there and we just haven't seen it yet. So I'll give you a great example of that. So lip tie causing recession on 24 and 25. This is a buddy of mine. We've been friends since 4th grade. He's been a patient for 20 years. And I took this video last summer when I'm like, oh, you got recession right here, and here's why, right? This week coming up, all your periodic exams, all your hygiene checks, hold their lip down. You're going to see this on someone, right? Where you'll see that little strain. And as you pull on that tissue, right, you'll see the gum actually pull down a little bit. So I'll show you this one in the case that we did a little more aggressive approach with an actual frenectomy and a vestibuloplasty. So at least he had some vestibule in there, right? So we're just pulling the tie away. Topical anesthetic, the compounded, just have a Q-tip that sits on either side of that frenum, let it sit for a minute, rinse it off, and then already on time, good. And just pull, I'm pulling on the lip to create a little tension in those fibers and just cut down until you get to, so how far are you gonna go? Just go to the bottom of the vestibule, and then that'll create a nice, like, smooth form and pull the tension off of the gingival tissue. All right. So let me show you, as we're wrapping that one up, let me show you this one, because this one's a little bit farther in there. So step one, and I'm gonna pause this for a second too. Backing up a little bit. This patient has no vestibule, right? It's just that his lip starts at that gum tissue, and you can see where it's causing that little recession. So if I'm going to send it to my favorite periodontist in the room to do grafting there, this is going to be hard because there's nowhere to put a graft, right? You can't have a graft under any tension at all. Otherwise the graft's going to fail, right? So step one is frenectomy. And then step two is I need to recreate a vestibule for this actually to fit in there, right? So step one is cut that frenum. I gave the good part away, showing you that healing already. Okay. So do that first part, do the frenectomy. Why did it skip past that? Let me see if I can. Okay, now, okay, here it goes. So now I'm actually going in there and starting to, at that line of attached tissue, I'll cut right below that and then down into kind of almost like along the parallel surface of the cheek. So the idea is as you're putting that tension on, you're essentially dissecting, imagine blunt dissecting the lip off the chin, right? And if you haven't done this before, point it at it, pull on it, it's gonna cut. You'll get it, right? And I'm just basically, now how low am I going? I'm just looking at the rest of the vestibule and I want to carry that line all the way around to the other side. Okay, that's how deep I want to go. My foot pedal is probably at 20 or 30% power and you're just painting away, right? So here's 1 week healing from that. Now, one of the things that happens too, actually, let me go back to this shot right here. So once I'm cut through there, the other thing then I'll do is I'll score pointing at the jawbone. I'll score a line with the laser right across the bone all the way to the periosteum. And the reason we do that is because it's almost like, I can't remember where we picked this technique up, but what happens is the attached gingiva grows down to that line. It's like drawing a line in the sand and the unattached heals up to that line. So we're actually boosting the amount of keratinized tissue on the facial portion, trying to minimize the need for a potential graft. All right. So then here's healing after 1 week. No sutures. There's no, we've been trying things like periopack just to get a deeper vestibule. Yep. Yep. And then dot that on the deepest part there. Yep. He's talking about basically sterile purple super glue, right? But you can see it's already starting to kind of fold in there, and you see as I'm pulling, I'm looking to make sure that there's no tension on that gum tissue at all. Right? So here's after 2 weeks of healing. And there's actually, a place where he can hide his gum again. Right? So here's 3 years later. I mean, look how stable that is, right? Now, there's been some cases where then we're like, okay, at least we created a more stable situation. There's some cases where we're like, I think we still need a little boost, and then we'll have you guys do the graft, right? I mean, but arguably made it a little easier for him to get in there. Part of the reason this is even like this isn't just the tension, is there's no vestibule to put your toothbrush in, right? So, well, again, what's the technique? Go down, let it heal, have them kind of, or her stick their tongue in there, over the week just to kind of put a little pressure on it, and then we create a stable periodontal result from that. Pretty cool. Techniques seem easy enough, right? So again, this is why this is the like class ones. I love doing class ones. Just kidding. I love doing this stuff, right? This is all approachable stuff that as a GP created that. This is that water off technique for the aphthous ulcer. So the water's off and I have it on a really low power and just kind of almost dehydrating. It is de-epithelializing, but you're kind of creating a little laser band-aid on there, right? Yes.
Not the distance of the biopsy.
Yeah.
When you do the laser, is it going to change the anatomy?
No, well, like if you're going to do a biopsy, let's take like a fibroma. So yes and no. On the short term, yes. Like when you do a fibroma, the technique is to actually take that ball of tissue and kind of almost pull up on it, and then you just laser across the bottom. Like I'm going to cut a broccoli stalk off. As soon as you cut through, that releases tension and goes boom, and it looks like a crater, right? But again, no, you don't have to suture it or anything. You just leave it there. And then 1 week later, it'll look flat again. So now an incisional biopsy, you might still be able to use the laser, but you're going to want to probably suture that. Depends on how big a chunk you're going to cut out. But in this case, because I'm not charring, because the other technique for a fibroma, right, is numb it, then elliptical incision around and cut under it, and then pull that out and then suture that envelope back together. Right? You don't have to do that.
Yeah, the technique.
Well, so that's what, so to keep it intact, as I pull up on that, and then I'm going to cut underneath there, you don't have a cooked edge at all. It's ablated, so you haven't changed the actual anatomy. You've just created this basically a little cut margin in there. Yeah. So, but then in your report, say CO2 laser and, like how you got it essentially, because they're looking for a scalpel edge and they won't see like an electrosurge burn in there. So, and then the other question that kind of comes up sometimes is, well, do we do every one? Like if it's right here, and you could, oh, I remember biting my lip and been there for 3 years and hasn't changed size, and every once in a while I bite on it again, and there's no ulceration. I won't necessarily send every single one of those away. But like, and to be honest too, like I had a couple years ago, a tongue cancer case where he came in like, oh, I lost my crown. Can you glue it back on for me? I'm like, yeah, absolutely. Right. And he's like, by the way, do you do anything with tongues? I'm like, well, you are at a dental office. I have a canker sore that's been there for a while. And I'm like, how much of a while? He's like, and this is like May-ish. He's like, since Thanksgiving. I'm like, does it hurt? He's like, nope. I'm like, oh shoot. Right. So huge crater on the side of his tongue. I'm not lasering that. I'm sending that to UCLA. Like if it's wacky, I'm sending it up the food chain. Right. So, but otherwise, little things. I would be careful around like an HPV lesion that you're not aerosolizing as you cut. So I go a lot farther around it. Not a lot, but I mean, I don't want to hit that directly. Yeah. Couple more things and then I think we'll take a break. So this is from Dr. Tim Anderson. He's in North Dakota. I just love how clean this whole picture looked, but you start to think about how we're using this just with soft tissue, just around cavity preparations, right? Is the ability to create this nice clean edge. And you're taking a traditional impression or a digital impression, there's no question how clear this is going to be. Again, back to just concepts to be thrown at you guys. The reason I love this is because this is taking other dentistry I'm doing, and this tool is making me better with that stuff to be able to kind of cross use it over there. Couple things on, I'm just trying to be sensitive to our time here because I got so much more to show you. Well, I'll show you part of this one. I'll just let it get going. Where, I mean, essentially we have, crown comes off, tissue's all grown over it on the distal. So the actual border of that tooth is down in here, right? So a lot of what crown lengthening can be is sort of, quote, closed crown lengthening, where essentially, and this is the class that you and I were talking about, what we want to teach. It's if you're not going to create pocketing in the bone, in this case, the bone is very vertical on the side of that molar down toward the floor. So I could just lower the whole height of that bone without necessarily flapping from here to there, right? And so getting in there, I want to do the laser. Sometimes the question is, well, should I prep it first? Well, I want to do the laser first because I want to clean up the tissue so my burr doesn't cut it. So I'd rather get the tissue out of the way, and then go in there and start just kind of cleaning that off. And you can see where I'm ever so slightly dotting against the side of that margin, but it's not a high enough power to actually cut that tooth, and it's only part of the spot size anyway. So I'm not worried that I'm gonna dig the tooth out. I'm gonna refine that a little bit with my burr anyway. And just start kind of cruising through. Now, as I get down in there, you see where the plume is getting a little brighter? That's bone on the side of that tooth. And all I need to do is go 2 millimeters past my eventual intended margin, and we're good, right? And that opens that whole thing up. Just skipping forward for time then. Another thing sometimes we'll do is if I'm worried I'm gonna create a pocket, where if the defect is down in between the teeth, I don't wanna just laser down in there and then leave a fin of bone here and a fin of bone here necessarily. So I want a nice smooth flow. So what we'll do is just basically do a small flap on either side and then laser all that bone tissue all through there, right? And then that's what lets me get away with then doing a little sling suture and going to a final restoration. But the good news is that I don't have to flap it from ear to ear. I could just basically get away with going in there and doing a smaller flap. And sometimes if I don't necessarily flap it, I don't have to necessarily go in and where's another case?